Is he present, Dr. Ashraf Hassan?
I'm here.
Yes.
Hi everyone. My name is Dr. Ashraf Hassan El Sayed. I'm a lecturer of medical oncology, hematology, and bone marrow transplantation in National Cancer Institute, Cairo University. And I want to thank Dr. Amel for invitation for this conference. I'm going to present today the role of HPV beyond the cervical cancer because of the expanding spectrum of the HPV-related malignancies. Why HPV-related cancers matter beyond the cervix? Because there is a rising instance of HPV-related other cancers, especially the oropharynx, distinct disease biology compared to tobacco-induced related tumors, and screening challenges due to lack of effective screening programs, and HPV status impact on prognosis, staging, and treatment consideration, and I will explain this later. Our learning objectives is understanding the HPV pathogenesis, cancer attribution to HPV, role of vaccinations, and focus on awareness and prevention. First, I'm going to speak about the biology and oncogenic pathogenesis of HPV. HPV structures, I will go rapid through this part. It's a non-enveloped double-strand DNA virus with high epithelial tropism, more than 200 genotype. High-risk virus genotypes include mainly 16 and 18. These are the most types involved in HPV-related cancers, with transmissions through contact, either skin-to-skin contact or skin-to-mucus contact via sexual or non-sexual methods. This is a very simple diagram illustrates the carcinogenesis stepwise process from HPV infection, persistent infection, which is the most important part in carcinogenesis, viral integrations, overproductions of E6 and E7 oncoproteins. Persistence of infection. HPV infection in most cases eliminated by the immune system, but when it gets persistent inside our body because of host immune response reaction or viral genotype or other tissue environment, will induce carcinogenesis, as will be explained in the next slide. Because of overproduction of E6 and E7 protein, E6 protein will lead to degradations of P53, which will induce dysregulation of DNA damage repair response, and E7 oncotype will lead to inactivations of retinoblastoma gene, and this will lead to sustained cell proliferations to impair DNA damage or chromosomal abnormalities. Then the process will start with precancerous lesions, like the low-grade squamous intraepithelial lesions, followed by high-grade, then carcinoma in situ, then invasive carcinoma. A spectrum and burden of HPV-related cancers beyond the cervix. As we all know, cervical cancers, 99% of cases caused by HPV infections, but other cancers like the anal, 90% caused by HPV infections, oropharynx 70 to 75%, vaginal 70%, benign 40 to 50%, and valvar 30 to 40%. HPV 16 subtypes is the dominant subtypes, followed by HPV 18, less dominant than HPV 16 in some cases. First, oropharyngeal cancers. There is a rising spectrum of rapidly increasing of the oropharyngeal induced by HPV infection, especially in high-income countries, affecting younger men, unrelated to smoking or alcohol. And this epidemiological shift were seen in some countries that oropharyngeal induced cancer by HPV exceeded cervical cancers in some regions, making significant change in HPV-related cancers. The etiological rule in oropharynx, high risk type, especially HPV 16, is the major cause. 60 to 70% of the cases were positive for HPV infection. The oropharynx had, which part of oropharynx, especially tonsil and base of the tongue, because of reach of lymphoid tissues, vulvar rings, that facilitate the infection's persistence and support viral persistence and replication later on to produce cancer. Nowadays, we usually do immunohistochemistry on the samples to detect B HPV B16. And the prognosis of HPV-related oropharyngeal cancers is much more better. And so now we have a separate staging system on NCCN due to better prognosis. They have better overall response, better overall survival. 3-year survival is an 80% in early cases compared to 50% HPV-negative cancers. And better response to chemoradiotherapy. So in such cases, we usually start with chemoradio treatment rather than surgery, and we preserve surgery later on in recurrence or progression. In case of anal cancers, it's also responsible for around 70 to 80% HPV-16 infection and HPV-18 less commonly. High risk include the HIV positive patient, men who have sex with men, immunocompromised, especially transplant patient, and patient with history of HPV-related disease like cervical dysplasia. Prognosis rule also. Like the oropharyngeal cancer, the anal cancer, HPV positive had a better prognosis, better response to chemo and immunotherapy, and better overall survival. The problem of HPV now worldwide is limitation of screening in non-cervical HPV-induced cancers. There is a screening gap. Most of non-cervical cancers lack validated screening programs, limiting early population level detection opportunities. Early detections will often recognize symptoms early because of those cancers usually discovered late when they are very advanced. There is an ongoing phase 3 trial now, ULACN NET trial 201, evaluate the benefit of HPV vaccines in reducing the oropharyngeal cancers, but the final cancer prevention outcome are not yet available because of long latency of oropharyngeal carcinoma development. This is a sample illustrations of approximate cervical and head and neck cancer incidence in Egypt. Cervical cancer is around 14 from each 100,000 women per year, and head and neck cancer incidence is around 10 to 100 population per year. Gender neutral impact of HPV, which is very important part that I want to speak about, because HPV can affect both sex. It does not only relate it to women. There's a high rising instance of men cancer related to HPV, like oropharynx, like benile, like anal. So promoting gender-neutral messaging will reduce the stigma and encouraging the higher HPV vaccination rate universally. HPV vaccine mechanism and rationale. It's virus-like peptide that mimic the virus outer shell but contains no viral DNA, making them safe and non-infectious. These particles trigger a strong neutralizing antibody response that prevent initial HPV infections by targeted genotype. The timing and vaccine is very important. It should be received early, ideally in pre-adolescent period, but also benefit later on for uncountered genotype. And limit age now, as I know, is 45. We can receive it up to the age of 45. I received the vaccine. Effectiveness of HPV vaccination in real-world setting, there is a high effectiveness proven. The real-world data, there is an over 90% reduction in HPV infection and precancerous lesions. Countries with high vaccination rates report declining HPV-related disease and early positive cancer trend. My clinical implication and conclusions and take-home message that HPV vaccination is expected to lower incidence of oropharynx, anal, benile, vulvar, and vaginal cancer significantly. Late impact pipeline benefit will be seen over 10 to 30 years because of cancer development latency after infection. Long-term vaccination program and policy support are essential to achieve sustained reductions in cancer incidence. Clinicians must communicate vaccine benefit as future cancer preventions to patients and public effectively. Thank you.
Thank you very much, Dr. Ashraf Hassan. It was very informative. Thank you so much. And now I have the pleasure to introduce my dear friend, colleague, and eminent